Hi, my name is Brad Steinman. I'm one of the anesthesiology residents at University Hospital's Cleveland Medical Center. And today we're going to be discussing an ENT operating room setup. ENT cases are typically kind of where you're going to get a lot of your difficult airways or at least abnormal airways. It's a great rotation for practicing different airway skills, getting familiar with different airway devices and ET tubes, as well as getting comfortable with other people messing with your airway. As a lot of the ENT surgeries involve the surgeon adjusting, disconnecting, pulling out, putting back in your ET tube during the case. Something you'll get more comfortable with as they go on. Today we're going to be discussing kind of how you can set up for an ENT case and different things to consider to make your rotation more successful. So for our ENT setup, we want to, for the most part, get ready with the same general case. We still want to follow our MS maids, make sure our machine's ready to go, we have our suction available, our monitors are all hooked up and ready to go. When it gets to the airway, it's typically a little different. Because we have an abnormal airway most of the time, I still like to have a DL blade available and ready to go. That being said, a lot of our ENT attendings and the ENT surgeons prefer if we use a video scope. This traditional glide scope is the preferred video laryngoscopy that we use on ENT. We have different sized blades in here, and it also comes with stylets that are metal that work and kind of align with the curve of the blade. Important to note, when you are using these stylets, please use lubricant when you're putting it in the ET tube, otherwise it can be very difficult to remove it out of the ET tube. Just to show a little difference between our two blades here, if we compare the angulation of our glide scope blade compared to the angulation of our MAC blade, we can see that the glide scope blade does have a more sharp or more acute angle on the blade. This can help with some more anterior airways or some of our more difficult airways. We still want to have our IVs ready, set up and ready to go. For a lot of our ENT cases, we do not need an A-line, but for some of the bigger cases, flaps, you will likely have an A-line, so make sure you have an A-line bag ready to go as well. And then there are some differences with drug management for ENT cases, so let's take a minute to discuss some of those changes. When thinking about what drugs we're going to draw for our ENT cases, it's important to consider some of the different cases they're going to be doing. And a lot of the cases are going to be doing nerve monitoring, whether it's neck dissections looking at the recurrent laryngeal nerve, parotid dissections looking at the facial nerve, or some of their middle ear surgeries. They're going to be doing a lot of nerve monitoring. And when they're doing nerve monitoring, you typically cannot paralyze for those cases. Most of the time, you're able to use paralytic for your induction and intubation, but after that, they prefer if your paralytic agent wears off so that they can do their nerve monitoring. So for our induction agents, we will typically drop the same stuff. We'll have our propofol ready to go for hypnotic agent. We'll have fentanyl ready for analgesia and to blunt our sympathetic response. Typically, if these patients verse as well, I'll have our lidocaine syringe. And then we will either have rocuronium or succinylcholine, but like I said, we'll usually only use this for the induction and intubation, and then we will let it wear off. So after we give it for the first heart, we'll usually just let it wear off. The additional thing we have is typically we will have remifentanil. Remifentanil is a synthetic opioid that we use. It is a very quick on and a very quick off, so we will infuse it with the patient throughout the case. It is very good at hemodynamic control. It can control blood pressure very well. It is also very good at helping to prevent movement to surgical stimulus. So it kind of acts as our proxy for a paralytic throughout the case. The way you mix this is you take 50 cc's of fluid that you can draw off your bag or wherever, and then you mix it with the vial of remifentanil. The remifentanil comes as a powder that you reconstitute in this 50 mLs. It is a 1 milligram amount of medication, so when you dilute it down, it dilutes to a concentration of 20 mics per ml. And it's very important that you dilute it to that because it's a very highly concentrated drug and you do not want to be off in your dilutions. So 50 cc's will mix with the 1 milligram of medication to make a 20 mics per ml of remifentanil. Once you have it in the syringe, you attach this tubing that you can find in your airway part over here, and then it actually hooks up to a syringe pump for infusion. This is our syringe pump that we use. There are some newer ones that hook up to the Alaris pump. They're functionally similar, hooking them up is the same, and they work the same as using the Alaris. So I'll show you how this one works. So you have your tubing here. We've already flushed the tubing through as well. This wing of the syringe connects in right there. It locks into place. This clamp slides around and it holds onto the syringe. And then we click right here, we open this up and we attach it to the back plunger of our syringe. This is now hooked up and ready to go. We will turn this on. It will take 1 second to turn on. Now that this is turned on, remifentanil 20 mics per ml is already a preset here. It's number 3, so we can press number 3. Done that. Is now pulling up. It has our patient's weight in here as 70 kilograms, so before you get started, you must change the weight if needed to change weight down here. It already is ready to go. It is set to a baseline dose of 0.05 mics per kilogram per minute. That is an okay dose to start with. As I said, this is a very potent medication that can very much drop your blood pressure if given too quickly, so this is a decent dose to start with, although I would say most patients typically run at 0.1 mics per kg per minute. But once we have this in, we have our correct weight, we have our correct dose, we will simply press start. And these lights moving across the syringe indicate that the syringe pump is working and the medication is flowing. When you need to stop it, you'll simply press stop. And that is how you use the syringe pump. As mentioned previously, on ENT you'll encounter a lot of abnormal airways. On this rotation, more than any, it's important to discuss with your attending the type of airway you are going to use, as well as discussing with the surgical team what type of airway they prefer. For a lot of the normal cases, you'll still use a smaller tube than normal, just to help stay out of their way. But I brought a couple different airways that we may commonly use in ENT over here. So this first one is an oral ray tube. This is meant to go in the mouth, and this bend in here is like a prefixed bend just to help kind of keep the tube out of the surgeon's way if they're working up on the maxilla, in the nose, something like that, that stays out of the way. This next tube is a nasal ray tube. This is also a ray tube, but it's meant to go in the nose. So this goes in through here, and then this will also move up and go over the forehead to stay out of the surgeon's way. This is a reinforced tube. A lot of times if they're doing a lot of cutting or surgery or you have a trach site, you may put a reinforced tube in there to help out with that. And then this right here is a laser protected tube. This is safe to use with lasers that they may use during ENT cases. This 10-ax tube is another type of laser resistant tube. This one's more expensive, so we're not going to open it. But that being said, these are all different types of tubes that you may need. During your time on ENT, it's important to discuss with your surgeon the morning of surgery and if you're attending the night before on which type of airways you're going to use. Since we discussed lasers, and we have laser resistant tubes here, it's important to remember that when they're using lasers, you're going to need to drop your inspired oxygen down to roughly 30%. And that's important that you also give time for the oxygen level to drop, because if you switch it to 30% as soon as they are ready to go, they're still going to be breathing a higher percentage of oxygen than the 30%. So give them time. If you know they're going to be starting to use the laser soon, turn your oxygen down, let the patient breathe it off to make sure you're safe, and you're going to do everything you can to prevent airway fires. One type of airway that I wanted to show you that we do not have in our workroom is a NIMS tube. A NIMS tube is an endotracheal tube that has wires in it to monitor nerve function within the tube itself. It's typically used to monitor the recurrent laryngeal nerve at the vocal cords. You'll use it often in neck dissections or thyroid surgeries, and when you place it with a glide scope, and the ENT surgeon usually kind of tells you how far to advance it to guide it so that the electrodes end up kind of exactly at the vocal cords and are going to do adequate monitoring for them. So if you're doing kind of neck surgeries or thyroid surgeries, be sure to ask the OR nurses if they're going to use a NIMS tube so they can grab it for you so you're prepared in the morning. So this is a quick overview of an ENT OR setup. Make sure you go through your MS maids as usual. If they're doing any sort of nerve monitoring, make sure you have remifentanil ready to infuse into the patient. And make sure you have open discussion with your attending and the ENT surgeon about the airways you're going to use. This also needs to move forward into the case, as a lot of the times, as I said, the surgical team will be messing with or adjusting the airway. And so if you see things on your ventilator that don't add up, make sure you ask them if they're doing anything with the airway, because a lot of times the answer is they'll say they disconnected the circuit or they pulled it out for a second. And having a good open communication with them is very important in these cases. It can make things a lot less stressful. So good luck on your ENT rotation, and I hope this video was helpful for you. Thank you.